Welcome to Cardio Radio, a podcast of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. This is Dr. Michael Constant from the Case Western Reserve University School of Medicine, and I serve as the principal investigator for Cardio, a statewide network of Ohio's 7 medical schools. Cardio is funded by the Ohio Department of Medicaid and shares best practices to improve cardiovascular health, diabetes outcomes, and to eliminate health disparities in Ohio's Medicaid population. The opinions and recommendations in this podcast are those of the presenters and not those of Cardio and its sponsors, and are not intended to be a substitute for medical advice. I hope you enjoyed today's podcast.
This is Dr. Deborah Gordish, Associate Professor from The Ohio State University and member of Cardi-OH's Team Best Practices. In this podcast, we will discuss the prevention and management of heart failure for patients with hypertension and diabetes. With me today is Dr. Ian Neeland. Dr. Neeland is an Associate Professor of Medicine at Case Western Reserve University and serves as the Director for Preventive Cardiology and Director of the Center for Integrative and Novel Approaches in Vascular Metabolic Disease Program in the Harrington Heart and Vascular Institute of the University Hospitals Health System. He is also a member of Cardi-OH's Team Best Practices. Dr. Neeland, thank you for joining us today.
Thank you, Dr. Gordish. It's my sincere pleasure.
We know that heart failure is an increasingly prevalent condition. Data from the National Health and Nutrition Examination Survey, or NHANES, showed that between 2017 and 2020, about 6.7 million Americans over the age of 20 had heart failure. The prevalence of heart failure is projected to increase by 46% by the year 2030. I can't help but to wonder how this might be tied to increasing rates of hypertension and diabetes. Dr. Neeland, what is the evidence linking hypertension and diabetes with heart failure?
So, we know that the traditional cardiometabolic risk factors such as hypertension and diabetes account for a large proportion of heart failure risk. Data from Olmsted County, Minnesota, published in 2009, indicated that hypertension accounted for 20% and diabetes accounted for 12% of the population attributable risk for heart failure. Now, heart failure is strongly related to increasing age, with between 8 to 11% of individuals age 80 and above having heart failure, compared with only 1 to 2% of those age 40 to 59. Since hypertension and diabetes traditionally have appeared in middle age, the risk for heart failure in that population tends to increase steadily after age 50 and can be directly related to these risk factors and their underlying causes, such as obesity. In fact, in a cohort of over 12,000 non-Hispanic Black individuals from the Jackson Heart Study and their GUARDS study, over 14 years of follow-up, the multivariable adjusted hazard ratio associated with hypertension compared to normotension was close to twofold higher for incident heart failure.
Clearly, hypertension and diabetes are important risk factors for heart disease. I wonder if you can help us understand just how common these risk factors are and how they might vary by different populations, such as by sex and/or race or ethnicity.
Sure. So, for example, in the coronary artery disease development in young adults, otherwise known as the Cardi-OH study, among those who are free of hypertension at baseline, the incidence of hypertension, defined as systolic blood pressure greater than or equal to 130 millimeters of mercury, diastolic blood pressure greater than or equal to 80 millimeters of mercury, or self-reported antihypertensive medication use, by 55 years of age was 75.7% in Black females, 75.5% in Black males, 54.5% in white males, and 40% in white females. On the basis of the previously mentioned NHANES study from 2017 to 2020, the age-adjusted prevalence of diagnosed diabetes in adults at least age 20 years varied by sex, between 11 and 18% in males and 8 to 15% in females, as well as race and ethnicity. Non-Hispanic white adults with more than high school education had the lowest prevalence, 7.9%, and Hispanic adults with less than high school education had the highest prevalence, 16.2%. And the prevalence of diagnosed diabetes in non-Hispanic Black adults was somewhere between 12.3 and 13.8%.
So, hypertension and diabetes are very common, but how do they cause heart failure?
So the incidence of heart failure from hypertension and diabetes is directly related to complications from these conditions, namely hypertensive vascular and cardiac changes, and microvascular and macrovascular complications in diabetes. One study, known as the Look-Ahead study, evaluated 4,095 individuals with type 2 diabetes, and that study found that microvascular disease in adults with type 2 diabetes, free from heart failure, was associated with a 2.5-fold higher risk of incident heart failure than no microvascular disease, including hazard ratios of 2.22 for nephropathy, 1.30 for neuropathy, and 1.33 for retinopathy in that population.
We know that about 50% of all heart failure now is heart failure with preserved ejection fraction, or HFpEF. Patients with HFpEF have similar mortality rates after diagnosis as those with heart failure with reduced ejection fraction, or HFrEF. So both types are equally devastating clinically. What unique aspects of hypertension relate to HFpEF specifically?
So hypertension is by far the most frequent morbidity present in HFpEF, with its prevalence reaching 80% in some studies such as Get With the Guidelines Initiative, and 90% or more in large randomized clinical trials testing the effectiveness of medical treatments in HFpEF. The type of heart failure really depends on several factors, including hypertension severity, duration, and antihypertensive treatment effectiveness, as well as the balance between left ventricular pressure and left ventricular volume overload, the coexistence of other comorbidities such as obesity, diabetes, and coronary artery disease that pre-exist or modify left ventricular hypertrophy development, and finally, disease modifiers such as age, sex, genetics, and others. A patient with hypertension may develop what's called concentric left ventricular hypertrophy, which is a risk factor for HFpEF. Also, hypertension may exacerbate or result from other HFpEF risk factors such as old age, obesity, diabetes, and atrial fibrillation. So there's a lot of interconnectivity with those risk factors in HFpEF.
Wow. So it is really important to identify these risk factors and assess risk for heart failure to prevent development. How might the practicing clinician assess risk for heart failure related to hypertension or diabetes?
So there are several heart failure risk scores that consider clinical risk factors among individuals with and without type 2 diabetes. So for example, these include the thrombolysis and myocardial infarction risk score for heart failure and diabetes, otherwise known as the TRS-HFDM, and the WATCH-DM risk scores for patients with diabetes. And then there's a separate score, the PCP-HF score, which calculates the risk of heart failure over a 10-year time horizon in the general population, those without necessarily diabetes. These scores are modeled after the pooled cohort equations risk score, which we use for atherosclerotic cardiovascular disease prediction, except that they may also include measures for other things like body mass index, QRS duration on the ECG, history of other cardiovascular conditions, and laboratory markers of kidney disease. Now, it's important to mention that natriuretic peptides, both the B-type natriuretic peptide, or BNP, and NT-proBNP, have been studied as screening tools for future heart failure. The STOP-HF trial tested the strategy of BNP-based screening with reflex collaborative care, meaning that at least an annual specialized cardiovascular review, which could include Doppler echocardiography, repeat BNP measurement, and other investigations. And that trial showed that among patients at risk for heart failure, this approach reduced the combined rates of left ventricular systolic dysfunction, diastolic dysfunction, and future heart failure events. Similarly, in the Pontiac trial, 300 patients with type 2 diabetes and increased levels of NT-proBNP greater than 125 picograms per milliliter, but who were free from cardiovascular disease, were randomized to either standard treatment at diabetes care units or what they called an intensified strategy, in which patients were additionally treated at a cardiac outpatient clinic for the uptitration of renin-angiotensin-aldosterone system inhibitors, or RAS blockers, and beta blockers. Primary endpoint of hospitalization or death due to cardiovascular disease at 2 years was actually significantly reduced with the use of the intensified strategy. The hazard ratio was 0.35 in that study. Now, there are several studies that investigated the cost effectiveness of this approach to screening for asymptomatic left ventricular systolic dysfunction using BNP testing. It seems to be cost effective, with less than $50,000 per quality adjusted life years gained when used in a population with a prevalence of heart failure of at least 1%. Now, these results are so important, they're incorporated in the 2022 Heart Failure Guideline for the American College of Cardiology, American Heart Association, and Heart Failure Society of America, with a Class 2A recommendation that in patients at risk for developing heart failure, such as those with hypertension or type 2 diabetes, as we're discussing today, that BNP or NT-proBNP-based screening, followed by team-based care, including referral to a cardiovascular specialist if needed, can be useful to prevent the development of left ventricular dysfunction or new onset heart failure.
Let's focus on hypertension for a moment. Over the past decade, there has been a movement for lower and lower blood pressure targets for the population. Does this hold true for heart failure risk as well? And what is the appropriate blood pressure target to reduce heart failure risk in persons with hypertension?
So that's a great question. Hypertension is defined in stages according to the most recent American College of Cardiology, American Heart Association blood pressure guidelines. Stage 1 hypertension is currently defined as 130 to 139 systolic or 80 to 89 millimeters of mercury diastolic, and stage 2 hypertension is greater than or equal to 140 systolic or greater than or equal to 90 millimeters of mercury diastolic. Now, numerous studies have shown that antihypertensive therapy reduces atherosclerotic cardiovascular disease events, heart failure, and microvascular complications in diabetes. And in general, every 10 millimeter per mercury reduction in systolic blood pressure is associated with a 28% reduced risk of heart failure. Now, for patients with diabetes and hypertension, blood pressure targets should be individualized through a shared decision-making process that addresses cardiovascular risk, potential adverse effects of antihypertensive medications, such as hypotension, and patient preferences. However, for individuals with diabetes and hypertension at high risk for heart failure, a blood pressure target of less than 130/80 millimeters of mercury is appropriate.
How might hypertension and diabetes interact when it comes to heart failure?
So hypertension is exceedingly common in individuals with type 2 diabetes, and it's a modifiable risk factor for heart failure. The 2023 American Diabetes Association and American College of Cardiology, American Heart Association guidelines recommend initiating antihypertensive medications for persistently elevated blood pressure of greater than 130/80 millimeters of mercury and a target blood pressure of less than 130/80 millimeters of mercury if safe and feasible. Targeting a lower blood pressure in a safe manner may also further reduce heart failure risk. For example, in the SPRINT trial, heart failure was reduced by 38% in those randomized to less than 120 versus less than 140 millimeters of mercury. ACE inhibitors or angiotensin receptor blockers, otherwise known as ARBs, are really the preferred agents to treat hypertension in individuals with type 2 diabetes, especially in the presence of albuminuria. It has been shown that thiazide diuretics and ACE inhibitors are more effective at reducing the risk of heart failure than calcium channel blockers. Doxazosin should be used with caution, since it was associated with an increased risk for heart failure compared with chlorthalidone when used to treat hypertension in people enrolled in the trial known as ALLHAT.
Another common medication class used for hypertension and heart failure is the mineralocorticoid receptor antagonists, MRAs, such as spironolactone. There has been quite a bit of new research in this class, especially with the non-steroidal MRA, finerenone. What are your thoughts regarding this class of medications for heart failure in relation to hypertension and diabetes?
So occasionally, people with hypertension who are receiving optimal doses of ACE inhibitors or ARBs could exhibit residual overactivation of the mineralocorticoid receptors. And in that case, MRAs are useful as adjunctive therapy. Now, steroidal MRAs, such as eplerenone and spironolactone, which have been around for a while, reduce albuminuria, but frequently cause hyperkalemia, especially when used in conjunction with ACE inhibitors or ARBs. They are indicated for heart failure with reduced ejection fraction based on prior trials such as RAILS and Ephesus. But a newer alternative, MRA, which is called finerenone, which is a non-steroidal MRA, has been approved for people with diabetic kidney disease. Now, compared with steroidal MRAs, finerenone is believed to have a higher potency and exert a less risk of hyperkalemia. The trials known as Fidelio-DKD and Figaro-DKD are complementary clinical trials that examine the kidney and cardiovascular effects of finerenone among people with type 2 diabetes and chronic kidney disease. In those trials, finerenone significantly reduced the risk of heart failure in the Figaro-DKD trial, with a non-significant relationship found in Fidelio-DKD. And in a pre-specified pooled analysis of these two trials, the reduction in a composite cardiovascular outcome was actually mainly driven by reductions in hospitalizations for heart failure, with a hazard ratio of 0.78. The American Diabetes Association recommends the addition of an MRA to treat hypertension in patients with type 2 diabetes if they are not meeting blood pressure goals, despite being on 3 classes of antihypertensive medications, including a thiazide diuretic. Finerenone can be considered in people